shock, and mainly we will discuss after it pathogenesis of septic shock from Robbins. Clear? So starting with the first definition of the shock. So shock is a state in which diminished cardiac output or reduced effective circulating blood, either of these two. Again, it is a state in which diminished cardiac output or reduced effective circulating blood volume impairs twitching, impairs tissue perfusion, okay, which leads to cellular hypoxia. So this is the whole definition of shock, how you will define the shock. So again, shock is a state in which diminished cardiac output or reduced effective circulating blood volume impairs tissue perfusion and which leads to cellular hypoxia. Clear? Now, the cellular injury, and at initial stages the cellular injury is reversible. Clear? However, prolonged shock eventually lead to irreversible condition. So initially the shock is reversible, but after a long time it converts into irreversible state. Clear? Now, shock may complicate severe hemorrhage, extensive trauma or burns, myocardial infarction, pulmonary embolism, like this. Now, its causes, the causes of the shocks are categorized into three general categories. Okay, the first one is your cardiogenic shock. Okay, first one is your cardiogenic shock. So cardiogenic shock results from low cardiac output due to pump failure. Due to pump failure, there will be low cardiac output, and that lead to cardiogenic shock. And now, and this pump failure is due to, it may be due to intrinsic causes. Okay, intrinsic myocardial damage, as we have seen in case of infarction or ventricular arrhythmia, or there may be extrinsic compression of vessels. Okay, extrinsic compression, as we have seen in the case of cardiac tamponade. Okay, or the third reason may be outflow obstruction. There may be outflow obstruction which is seen in pulmonary embolism. So these are the main reasons. Again, repeating cardiogenic shock results from low cardiac output due to myocardial pump failure. Now, this can be due to intrinsic myocardial damage, that is infarction, ventricular arrhythmias, okay, or extrinsic compression such as in cardiac tamponade, or outflow obstruction, that is in case of pulmonary embolism. So these are the causes of cardiogenic shock. Now, the next one is hypovolemic shock. The next one is your hypovolemic shock. So it results from low cardiac output, and that is due to low blood volume. Low cardiac output due to low blood volume, that lead to hypovolemic shock. Okay, and it can occur due to certain hemorrhages. Mainly it is related with the low blood volume. Low blood volume means fluid loss, that may be by hemorrhage, vomiting, diarrhea, burns or trauma. They are the common reasons in which blood volume decreases, that lead to hypovolemic shock. Now, the next is your shock associated with systemic inflammation. Shock which are associated with systemic inflammation. Clear? Now, it may be triggered by variety of reasons, particularly your microbial infections. Okay, it is microbial dependent, that leads to microbial infection, or non-microbial causes are burns, trauma or pancreatitis. Okay, so these are the non-microbial causes of the shock, and these are the microbial causes which can lead to shock which is associated with systemic inflammation. Now, the common pathogenesis, the common pathogenic feature in this type of shock is your massive outpouring of inflammatory mediators. This is the main pathogenesis. Okay, outpouring of inflammatory mediators from innate and adaptive immune cells that lead to your arterial dilation. Okay, that lead to vascular leakage, that lead to venous blood pooling. Clear? So once again, repeating, shock associated with systemic inflammation may be triggered by variety of reasons, particularly microbial infections or non-microbial such as burns, trauma or pancreatitis. The common pathogenic feature is a massive outpouring of inflammatory mediators from innate and adaptive immune cells that produce three things mainly: arterial vasodilation, vascular leakage due to increased permeability, and the third one is venous blood pooling. Clear? Now, these cardiovascular abnormalities, these three cardiovascular abnormalities lead to hypoperfusion, okay, which we have discussed, hypoperfusion which causes your cellular hypoxia, and certain metabolic dearrangement that ultimately lead to hypoperfusion that leading to slow hypoxia, as well as metabolic dearrangement that lead to organ dysfunction. Clear? And if persistent and severe, then there may be death. Clear? Now, it should be noted here that diverse triggers of shock, that is microbial and microbial associated with inflammation, produce a similar set of clinical findings which are referred to as systemic inflammatory response syndrome. Clear? Once again, it should be noted here that diverse triggers of shock, that is maybe microbial or non-microbial, associated with inflammation, produce a similar set of clinical findings which we are referring to systemic inflammatory response syndrome. Okay? Now, these are the three main classes of the shock. There are other classes as well, such as neurogenic shock. It is due to anesthetic accident, okay, or a spinal cord injury. So spinal cord injury may be associated with this. Another one is anaphylactic shock, okay, that is due to IgE mediated hypersensitivity reactions. Clear? So this is about the general introduction of shock and its type. Now we will discuss about the pathogenesis of septic shock. Pathogenesis of septic shock. Okay, so septic shock ranks first among the causes of death in intensive care unit and accounts for over 2 more than 2 lakhs lost life each year in the United States. Okay, so this is the first which major cause of the death in intensive care units. Clear? Now, it is increasing. It is seen in mainly in those patients which are in immunocompromised state. Okay, their immune system is in compromised state, or there may be advanced age. Okay, the other is advanced age, which is related to immune compromission, because as age advances, your immune system functions get decreased. Clear? And also due to increasing prevalence of multi-drug resistant organism in hospital setting. Clear? So these are the common reasons. And septic shock is most frequently triggered by your gram positive infection. Okay, then your gram negative, and then fungi. So the main responsible is gram positive, then gram negative, and then fungi. Okay, this is the important MCQ question. Clear? Now, we will now move for the pathogenesis of septic shock, how septic shock is occurring. So the first step, that is initiators of inflammation in sepsis, are signaling pathways that lie downstream of toll-like receptors, which you are knowing. Toll-like receptors, it is present on the cells of the host. Okay, in this toll-like receptor will recognize microbial products, that is also known as MAMPs. Okay, that is pathogen associated molecular patterns. Okay, so this toll-like receptor present on our immune cells, okay, which will recognize PAMPs, that is pathogen associated molecular patterns. Clear? And along with toll-like receptor, there is also presence of G protein coupled receptor that redact other bacterial peptides and nucleotide oligomerization domain proteins such as NOD1, NOD2. Okay, so once again, initiators of inflammation in sepsis are signaling pathway that lie downstream of toll-like receptor, which you will recognize a host of microbe-derived substances called as pathogen-associated molecular patterns, as well as G protein coupled receptor that detect bacterial peptides and nucleotide oligomerization domain proteins such as NOD1, NOD2. Clear? So this is the first step, that is recognition is occurring. Now, what will occur? So after recognition, it will lead to 3 things. The first one is neutrophil and monocyte activation will be there. Okay, or second is endothelial activation will be there, and the third one is your factor 12 activation. Okay, along with this also sometimes complement activation is also there. Okay, there will be complement activation. So factor 12 activation, complement activation, then your endothelial activation, and neutrophil and monocyte activation. Clear? And after this factor 12 is acting as procoagulant, as you are knowing. Okay, factor 12 is acting as procoagulant. It will increase amount of tissue factor. Clear? And it will downregulate the thrombomodulin. It will downregulate thrombomodulin, protein C, like this. Okay. Now, this endothelial activation can lead to various of the effects. First, endothelial activation may lead to procoagulant activation as well as anti-fibrinolytic pathway activation, means increasing plasma activator inhibitors amount, okay, procoagulant and antifibrinolytic. Endothelial activation also lead to release of interleukin 6, interleukin 8, NO, PAF, platelet activating factor, and other oxygen species, reactive oxygen species. Clear? Now, this neutrophil and monocyte activation can lead to release of your 10 tumor necrosis factor, as well as interleukin 1, as well as your HMGB1, okay, that is high mobility group box protein 1, high mobility group box protein 1. Clear? And this can lead to endothelial activation. It will promote endothelial activation. Complement activation also promote endothelial activation. Clear? Now we will discuss the effect of this, how these all are affecting again. So first, that is procoagulant and antifibrinolytic effect. As we discussed, procoagulant and antifibrinolytic effect. So these two will cause microvascular thrombosis, that is, okay, DIC, disseminated thrombosis. So it will lead to microvascular thrombosis, and due to this there will be tissue ischemia, and due to this tissue ischemia that may lead to adrenal insufficiency. We will discuss what is adrenal insufficiency here. Okay, now we have also discussed that there will be formation of interleukin 6, interleukin 8, NO, platelet activating factor, reactive oxygen species. Okay, they all lead to vasodilation, increased vascular permeability, okay, decreased perfusion, because there is vasodilation, there is increased vascular permeability, so there will be decreased perfusion, and this tissue ischemia and these all effects, these three effects can together lead to multi-organ failure. They together lead to multi-organ failure. Clear? As well as we have seen the formation of TNF, IL-1, as well as HMGB1. Okay, these all also have effect on systemic. These also causes systemic effects such as fever, diminished myocardial contractility, metabolic abnormality, that also lead to multi-organ failure. Clear? Now there are also certain secondary anti-inflammatory mediators. Okay, there will be activation of interleukin 10, apoptosis mechanism will be activated, okay, like this, and this will promote anti-inflammatory response, and that will cause your immunosuppression. Clear? Now once again revising the whole pathway. Clear? So we have seen first step is your recognition by toll-like receptors, okay, as well as certain G protein coupled receptor also there. Upon activation, innate immune cells produces, we have seen tumor necrosis factor, interleukin 1, interferon gamma, IL-12, IL-18, as well as other inflammatory mediators such as high mobility group box 1 protein, that is HMGB1. Reactive oxygen species and lipid mediators such as prostaglandin, platelet activating factor are also formed there. And now these effector molecule induce endothelial cell to upregulate adhesion molecule expression and further stimulate cytokine and chemokine production. The complement system we have seen also activated, okay, which lead to formation of anaphylatoxin C3S, C5A, chemotactic fragments C5A, opsonins, C3B, all of which are contributing to pro-inflammatory state. In addition to this, microbial component can also activate coagulation directly by activating factor 12, as we have seen, and indirectly through altered endothelial function. Now, this accompanying widespread activation of thrombin may further augment inflammation by triggering, we have discussed, triggering PR, that is protease activated receptors on inflammatory cells. Clear? Now, important point, the hyperinflammatory state, which is initiated by sepsis, also activates counter-regulatory immunosuppressive mechanism, which may involve both innate and adaptive immune cells. As a result, septic patient may oscillate between hyperinflammatory and immunosuppressive states. So, septic patient is oscillating between hyperinflammatory and immunosuppressive state, as we have discussed. It is oscillating between these two, hyperinflammatory state and immunosuppressive state. Clear? And the proposed mechanism for the immune suppression include a shift from pro-inflammatory to anti-inflammatory, that is shifting from TH1 to TH2. Clear? So we are shifting this immunosuppression is by due to shifting of the from pro-inflammatory to anti-inflammatory cytokines. Clear? And there will be also this is the first reason, There is also production of anti-inflammatory mediators such as soluble TNF receptor, interleukin 1 receptor antagonist, interleukin 1 receptor antagonist. Okay, so TNF receptors, interleukin 1 receptor antagonist, mind it, antagonist we are using, as well as interleukin 10. So these all are promoting immunosuppression. Clear? And also along with apoptosis of lymphocytes, as we have discussed, there will be apoptosis of lymphocytes. Okay, so these are the effects of immunosuppression. So either due to shifting from Th1 to Th2, TNF receptor, interleukin 1 receptor antagonist, or interleukin 10, or apoptosis increase. Clear? So this is about your how the major pathogenic pathway which are involved in septic shock. Clear? Now we will discuss about metabolic abnormalities which are associated with the septic shock. Metabolic abnormalities which are associated with septic shock. So septic patients exhibit two things very important, that is insulin resistance as well as hyperglycemia. Okay, so there will be insulin resistance as well as there will be hyperglycemia. Cytokines such as tumor necrosis factor, interleukin 1, as well as some stress hormone which is glucagon, growth hormone, glucocorticoids, okay, and certain catecholamines. So these three or either of these three, okay, this all three will promote your gluconeogenesis. Okay, so the first hyperglycemia, why there is hyperglycemia? Due to this TNF, IL-1, stress induced hormones, catecholamines, these all drive your gluconeogenesis. Clear? At the same time when there is ongoing glucogenesis, pro-inflammatory cytokines suppresses your insulin release. So there will be suppression of insulin release at the same time. Clear? Okay, and there will be also promotion of insulin resistance, decrease insulin release as well as increasing insulin resistance on the liver and other tissues, likely by impairing the surface expression of important glucose transporter, that is GLUT4. So the pro-inflammatory cytokine suppresses insulin release while simultaneously promoting insulin resistance in liver and other tissues, likely by impairing the surface expression of GLUT4, that is a glucose transporter. Clear? Now one more point, this hyperglycemia causes decrease in neutrophil function. This is very important. The hyperglycemia causes decrease in neutrophil function, thereby suppressing bactericidal activity and causes increased adhesion molecule expression on endothelial cells. Clear? So these are the effects such as insulin resistance and hyperglycemia. Now, depression of the one more cause which is related to this. Okay, although sepsis is initially associated with an acute surge in glucocorticoid production, this phase may be followed by adrenal insufficiency. Okay, we have seen that sepsis is initially associated with increased glucocorticoid production, as we have discussed, increased glucocorticoid production, but it may be followed by adrenal insufficiency, okay, and decreased glucocorticoids, okay, and this may be due to depression of synthetic. Two reasons are basically proposed for this adrenal insufficiency. First, there may be depression of synthetic capacity of adrenal gland. There may be depression of synthetic capacity of adrenal gland, or the second may be your frank adrenal necrosis. The second one is your frank adrenal necrosis, which is due to disseminated intravascular deamination. Okay, that is due to disseminated intravascular deamination. This is also known as Waterhouse. This is also known as This is also known as Waterhouse Fredrickson syndrome. Okay, the second one, the frank adrenal necrosis, is also known as Waterhouse Fredrickson syndrome. Clear? So this is about metabolic abnormalities which are associated with the sepsis. Now, coming to the next important point, the last, that is organ dysfunction. How organ dysfunctioning is associated with this septic shock. Clear? So systemic hypotension we have discussed. Because of the vasodilation, there will be systemic hypotension, there will be interstitial edema, okay, a small vessels thrombosis. All these three, the hypotension, edema, thrombosis, all these decreases your oxygen and nutrient delivery to the tissues, okay, which fail to properly utilize the nutrients that are delivered due to cellular hypoxia. Decreasing oxygen and nutrient delivery, also due to decreased oxygen delivery, that whatever the nutrients is reaching to the cell, that cell is not properly able to utilize that amount of nutrients as well, okay. High levels of cytokines and secondary mediators diminish myocardial contractility and cardiac output and increases vascular permeability and epithelial injury, which can lead to your acute respiratory distress syndrome as well. Clear? And ultimately, these all factors may conspire to cause the failure of multiple organs, including kidney, liver, lungs, heart, and finally to the death. Clear? Now, some important theoretical points, that the severity and outcome of septic shock are likely dependent on the extent and virulence of the infection. Okay, it will be more dependent on the extent and virulence of the infection. Clear? The first is your extent and virulence of infection. The second one is your immune status of the host. Okay. The third one is your the presence of other comorbid condition. The fourth one is your pattern and level of mediator production. Okay, pattern and level of mediator production. So the severity and outcome of septic shock may depend on extent and virulence of infection, immune status of host, comorbid conditions, okay, and pattern and level of the mediator's production. Clear? The multiplicity of factors and the complexity of the interaction that underlies sepsis explain why most attempts to intervene therapeutically with antagonists of specific mediators have failed to be effective and may even have had deleterious effects on the cases. Clear? Because there are so many reasons. Clear? Now, one important point, add an additional group of secreted bacterial proteins such as which are known as superantigens. It also causes a similar syndrome which is similar to septic shock, that is known as toxic shock syndrome. Okay, superantigens are polyclonal T lymphocyte activators that induce the release of high levels of cytokines that result in a variety of clinical manifestations resulting from a diffuse rash to vasodilation, hypotension, shock and death. Clear? So this is all about pathogenesis of shock, in which we have discussed first about major pathogenic pathways, then we have discussed about metabolic abnormalities. In that we have discussed about hyperglycemia, insulin resistance and adrenal insufficiency. Then we have discussed about organ dysfunction. Okay, how organ dysfunctioning is occurring, what are the reasons, and then we have discussed the factors on which severity and outcome of septic shock depend. Clear? And then toxic shock syndrome. Now the last part is stages of shock. What are the common stages of the shock? So the first phase is non-progressive phase. Okay. The second phase is your progressive stage. Sorry. And the third stage is irreversible stage. Clear? So non-progressive phase, during which reflex compensatory mechanism are activated and perfusion of the vital organs is maintained. Clear? So in early non-progressive phases of shock, a variety of neurohumoral mechanism help to maintain cardiac output and blood pressure. Baroreceptor mechanism, chemoreceptor mechanism, okay, catecholamine release, activation of RAS pathway, ADH release, and generalized sympathetic stimulation. So these all are included in non-progressive stage. Clear? And the net effect of these all are tachycardia. The net effect of all these are tachycardia. There will be peripheral vasoconstriction. There will be renal conservation of fluid. Clear? Now, cutaneous vasoconstriction, for example, is responsible for characteristic coolness and pallor of the skin in well-developed shock. Although septic shock can initially cause cutaneous vasodilation and thus present with warm flushed skin. So this is very important point. Okay. Again repeating, cutaneous vasoconstriction is responsible for characteristic coolness and pallor of the skin in well-developed shock. Although septic shock can initially cause cutaneous vasodilation as well. Clear? Now one important point, that coronary and cerebral vessels are very less sensitive to sympathetic response and thus it maintains relatively normal caliber blood flow and oxygen delivery. Clear? Now coming to the second stage, that is progressive stage. So it is characterized by tissue hyperperfusion and onset of worsening circulatory and metabolic imbalances, which include lactic acidosis. Okay, if the underlying causes are not corrected, shock passes from non-progressive to progressive phase, during which there is widespread tissue hypoxia. Okay, and in this oxygen deficit, intracellular aerobic respiration is replaced by anaerobic glycolysis with excessive production of lactic acid, and the resulting lactic acid lowers the tissue pH and also blunts the vasomotor response. Okay, arterial dilate and blood begin to pool in the microcirculation. Clear? So this is in progressive stage, and after that there will be irreversible state that sets in after the body has incurred cellular and tissue injury so severe that even if the hemodynamic defects are corrected, survival is not possible. Clear? So this is about your stages of shock. Now the last point, that is morphology. Okay, so the cellular and tissue changes induced by cardiogenic or hypovolemic shock are essentially those of hypoxic injury. Okay, it is essential, it is likely to be like the hypoxic injury. Okay, changes can manifest in any tissue, although they are particularly evident in mainly in brain, heart, lung, kidney, adrenal and gastrointestinal tract. Okay, the adrenal changes in shock are those seen in all forms of stress. Essentially, there is cortical cell lipid depletion. The important is cortical cell lipid depletion. Clear? This does not reflect adrenal exhaustion, but rather conversion of relatively inactive vacuolated cells to metabolically active cells that utilize stored lipid for the synthesis of steroid. Okay, so this is about your adrenal. Now kidney. So kidney typically exhibit acute tubular necrosis. Okay, it exhibit acute tubular necrosis. Then lungs. So lungs are seldom affected in pure hypovolemic shock because they are somewhat resistant to hypoxic injury. So they are resistant to hypoxic injury, so they are resistant. Okay, they are very less chances of hypovolemic shock there. Okay, however, when shock is caused by sepsis or trauma, there will be diffuse alveolar damage. Okay, diffuse alveolar damage may develop the so-called shock lung. In septic shock, the development of DIC leads to widespread deposition of fibrin-rich microthrombi, particularly in the brain, heart, lung, adrenal gland, and GIT tract. Clear? Now, two important points from CQ, that with the exception of neuronal and myocyte ischemic lock, virtually all of this tissue may revert to normal if the individual survives. Okay, unfortunately, most patients with irreversible changes due to severe shock die before the tissue can recover. So this is all about your shock from Robbins. Thank you.